I'm I am Stephanie Simmons. I am a child psychologist here at UT Health Science Center. I am not a native Texan. I grew up in North Carolina, but came to Texas and did grad school at Baylor. I then married a Texan, so I like to think that I am Texan through marriage, if nothing else. Like I said, I do a lot of work, outpatient work in our clinics with children, adolescents, and families, as well as working with our psychiatrists and our family medicine physicians on a variety of different behavioral health problems. So very excited to be here and to present with Dr. Kerr. Okay, are we ready to get started?
I think so.
All right. So quickly, our learning objectives for today, we are going to briefly touch on the importance of sleep, both for general daily functioning, physical functioning, as well as mental health. We're going to talk about the developmental changes of sleep across different ages from birth and through teenagers. We want to talk about ways to effectively and efficiently screen for pediatric sleep issues in a primary care clinic, and then spend some time discussing interventions for common pediatric sleep issues, including both behavioral as well as medication-based interventions.
So why is sleep so important? I think, first of all, if someone in the house is not getting sleep, then nobody is getting any sleep, as our title alludes to. So it definitely contributes to family well-being, but also it can have impacts on our heart and circulatory system, hormones, which in kids, especially teenagers, are very, very important to keep in tune, metabolism, respiratory system, immune system, thinking and memory. I think a lot of people don't, as adults, sometimes when we don't get a lot of sleep, we can kind of power through. But if as kids, they're not going to really kind of retain what they're learning in school if they're not getting good sleep, at night. And so then that can have an effect on academic performance. And then, of course, mental health is so intricately linked to sleep.
And I think it's interesting that, a lot of times we know what sleep deprivation looks like for us as adults. It typically means that we're dragging, maybe we're drinking a bunch of coffee, trying to get going, we're yawning, wanting to go to sleep. But sleep deprivation does not always present in that specific way in children and adolescents. Often it will manifest as irritability and grouchiness. And as we know, it can also mimic a lot of the symptoms of ADHD. So like Dr. Kerr mentioned, attention and memory can be significantly impacted when there is sleep deprivation in children and adolescents. So that may mean that they are distracted in class, having trouble consolidating information that they're learning, and that has very little to do with a learning disability or their innate abilities, and much more to do with the amount of sleep that they're getting. Like we touched on, a lack of sleep or poor quality sleep can be associated with a lot of difficult behaviors that can be associated with that irritability and grouchiness. Lower capacity to learn. It can also result in poor eating patterns and significant weight gain. It's also important to note that there's natural biological changes in the adolescent mind that affects when teenagers are feeling sleepy. So teenagers are often more tired in the morning and more awake at night, which is really problematic when we think about when schools and activities start. So schools start extremely early. You tack extracurriculars on top of that, and teenagers are up and moving very early. It's interesting, several school districts have enacted later start times, and research has shown that students attending school in those districts get more sleep, have fewer motor vehicle accidents, get better grades, and have improved mental health overall. I think it's also interesting that the American Medical Association and the American Academy of Pediatrics considers chronic sleep loss a public health problem. They link chronic sleep deprivation to a significant risk factor for substance abuse, car accidents, sports injuries, and mental health problems overall.
So how much sleep does your child need? This varies very widely over the kind of developmental span, and actually even among experts, there is sometimes not consensus on what the the right number is. But in general, this graph is a nice representation of how we kind of start needing, a lot of sleep, and it kind of whittles down. But sleep is critical for development. But sometimes parents are not aware of how much sleep their child actually needs. So they may not even recognize it as a problem that their, teenager is going to bed at midnight and having to wake up at 6 a.m. for sports practice or whatnot. They, may not even realize that that's not enough to kind of hit that target for their child. And even I think in the middle ages, that is a problem too. So getting kind of specifically into the developmental times, infant and toddler sleep needs. So infants need about 14 to 17 hours out of every 24 hours. Prior to 3 months of age, infants are kind of sleeping on and off throughout the day and night. And then between 2 and 3 months of age, infants will start to have sleep cycles and kind of sleep more at night. By 6 months, most infants will have kind of that longest chunk of sleep at night. Most infants under 6 will still need a kind of a feeding at night and also to kind of help soothe them and settle. So that's 6 months is about when kids can really, or when babies can make it through the night. And then from around 6 months, babies develop new motor abilities that can affect their sleep. So, they're starting to have, be more mobile, and this can make it a little bit more difficult for them to settle for sleep. They also can have natural separation anxiety, and so they may cry out for caregivers. And then they will overcome this anxiety as they mature, but it also sometimes takes parents understanding that that's kind of a natural response. It doesn't mean that they need to intervene, that kind of letting the baby self-soothe can be appropriate at times. In toddlers, the sleep need is 11 to 14 hours. Generally, toddlers are sleeping 10 to 12 hours at night and then napping about 1 to 2 hours during the day. They are also developing rapidly, so their sleep is changing quickly, and you'll see a lot of changes in how their sleep patterns. And toddlers really like to test their independence, so getting them to sleep may be more challenging, especially if they see with the rest of the family, older siblings aren't going to bed. It can be difficult to get them to want to go to bed. Some tips or some things that are important are kind of recognizing tiredness before it sets in. This can help grumpiness and also that like overtired sensation we sometimes see in younger kids. And then also a consistent bedtime routine can also help with sleep. Really, you can start a consistent bedtime routine as young as like 6 months, really trying to instill in baby and then toddlers. And then that's going to be a consistent recommendation for all of the ages. Is a consistent bedtime routine is really so huge for sleep hygiene. As we get a little bit older, in preschool, kids need about 10 to 13 hours a day. Some preschoolers may still nap during the day, and some will start to phase that out. Some of this is cultural too. There are some cultures where a nap, in the older preschool age is more common. Preschoolers may have sleep troubles like nightmares, night terrors, parasomnias may start to emerge in this age group, and then getting out of bed, being mobile, going to bug parents, waking everyone else up is an issue here. And again, a consistent bedtime routine is the best way to handle many of the preschool sleep problems. And then in our school age patients, elementary school age, they'll need 9 to 11 hours a day. Some children will fall deeply asleep immediately, but some may fidget and mumble before falling deeply asleep. We may have sleep problems here, including bedwetting, sleep apnea, nightmares, sleepwalking, and teeth grinding. And then relaxation before bed will help with better sleep. And this, again, can be a part of that consistent bedtime routine that we are talking about. As we get into the preteen and teenage sleep needs, they need about 8 to 10 hours a day, but it's actually estimated that 60% of middle schoolers and 70% of high schoolers are not getting adequate sleep each night. And there are some studies that show that a large proportion of teenagers say that they, are falling asleep doing homework and things like that. So it's definitely, I would say most teenagers are not getting that 8 to 10 hours of sleep. So some common pediatric sleep disorders that you might want to be thinking about if you have a patient that comes in and you've talked about the bedtime routine, and you really tried to make some sleep hygiene things. Obstructive sleep apnea can appear in this age, and it presents differently in kids than it does in adults. So in adults, we tend to associate it with that, maybe obesity, more feeling tired during the day. With kids, they may not be overweight. Typically, the treatment is kind of like tonsillectomy, adenoidectomy, and they may just be irritable, but not necessarily overtly kind of falling asleep during the day. The parasomnias are also kind of active in this age group. Sleepwalking, which I think we're all pretty familiar with. Confusional arousal, which is can cause individuals to act strangely as they wake up or just after waking. Can be behaviors like slurred speech, inappropriate behavior, or confused thinking. Sleep terrors are, different from nightmares in that these kiddos don't remember having the sleep terror, and it's generally scarier for the parents or the caregivers than it is for the kid, because they'll see their child in distress, but really it's happening during a time of sleep that the child will very rarely remember it the next day. And really just letting them grow out of this is the treatment there. And then nightmares we've kind of all heard of. Excuse me.
Behavioral insomnias are often extremely common in children, affecting like 10 to 30% of the population. And our behavioral insomnias fall into two types. We have a sleep onset association type and a limit setting type. So the sleep onset association type is really just any difficulty falling asleep or staying asleep without a specific stimulus. So this could be having a parent rock you to sleep, having a parent in the room, using a pacifier, anything like that. And families often, our slides went away. Hang on. 1 second. Take 2. All right. Sorry about that. Okay. So with behavioral insomnia, especially sleep onset association type, parents are normally noting that falling asleep is like a long and challenging process. So these behaviors are only classified as a disorder when they are persistent and when they are highly demanding and distressing to parents. So we may have toddlers and young children who are fighting going to bed, who are getting used to sleeping without a pacifier, who may not meet full criteria for a behavioral insomnia. The limit setting insomnia includes bedtime refusal, frequent awakenings, and refusal to sleep. And often parents who are sleep deprived themselves give in to the child by maybe letting them sleep in their bed, get up, watch television, etc. And so child gets in the habit of expecting that they can have these things and expecting that they can ask for these things rather than going to sleep. In older children, insomnia is often more related to stress or poor sleep hygiene. And it is important to note that idiopathic insomnia, so insomnia without an identifiable cause, is really rare and typically occurs in less than 1% of the population. As we touched on, older children and teenagers begin to have different sleep-wake cycles. And so in some teenagers, we may see this delayed sleep phase disorder. And so this is just changes in the adolescent brain that naturally shifts sleep phases later into the day and night. So we may call adolescents night owls, see them staying up very late. But sleep can actually become disordered when it's delayed by more than 2 hours. So if an adolescent is attempting to go to bed at 10 p.m. and is really unable to fall asleep until 12 p.m., we may consider that a sleep phase disorder. And then finally, restless leg syndrome. It's less common and affects only about 2% of children. Symptoms include the urge to move legs with associated distress. And those movements often begin in the evening and worsen as time goes on. It can be associated with an iron deficiency and can contribute to negative behavior and mood, but really needs polysomnography to actually be diagnosed. So when we are thinking about assessing for sleep problems, especially in a primary care setting, there are a couple of different routes that we can take. So usually our starting point is just using a clinical interview and some really specific questions. So we want to be accounting for how many hours a night the child is sleeping. And our focus really needs to be on daytime signs of insufficient sleep. So if a child is falling asleep or sleeping more on the weekends, if you're having trouble waking them up in the mornings, if they're taking more than 15 minutes to get going, or if they're falling asleep during sedentary activities like reading or watching TV, those are really signs that daytime sleepiness may be significantly impacting functioning. Beyond questions, we can also use a couple of ways to track sleep. So the Epworth Sleepiness Scale is a widely used screener. I'm sure we've all probably taken it or seen it at some point, but it's an 8-question screener that essentially produces a sleepiness scale based on how often and how likely you are to doze off in a variety of situations, like riding in a car, reading a book, watching TV, sitting in class, things like that. So the higher a score, the more likely it is that the child is experiencing significant daytime sleepiness and that their functioning may be impacted. When we are assessing for sleep problems, we also want to be thinking carefully about several risk factors. So we want to be screening for family history of sleep problems, such as sleep apnea that we know is fairly genetic. Child temperament, if they are just difficult and highly independent, that may be influencing how readily they take to a bedtime routine. Lifestyle factors, like Dr. Kerr mentioned, may include when everyone else in the house is going to bed, how active they are during the day, those types of things. We also want to be carefully looking at comorbid conditions like ADHD or anxiety. So, for example, a prescribed stimulant medication for ADHD, especially if it's taken later in the day, may make it difficult for a child to settle their body at night. Another important risk factor to consider is exposure to traumatic events. So PTSD symptoms can contribute significantly to nighttime fears and nightmares, and can also be a big factor in sleep avoidance. So something that we always want to be screening for when we're thinking about sleep problems in children and adolescents. Sleep diaries are often a great place to start when we really want to track kind of what is going on for a child when they are trying to go to sleep and throughout the night. So I have an example of a sleep diary on the next slide, but essentially we're going to be asking parents to log not only what time the child goes to bed, but also what time they fall asleep, when they're waking up at night, and any daytime naps that they're taking. So again, we want a full view not only of how many hours that they're sleeping a night, but also what that sleep looks like and what the sleep quality looks like. A slightly newer way of assessing for sleep problems is using actigraphs. So these are electronic devices worn on the wrist, like a Fitbit, like an Apple Watch, kind of anything that tracks sleep-wake cycles that measures the motor activity over the course of several days. So we can kind of see what those sleep-wake cycles look like and use that data to inform if we think that there is a disorder or if we think this is more behavioral. And then finally, if we do think that there is something more medical, we always want to be thinking about referring for sleep testing. So medical disorders such as sleep apnea, narcolepsy, and restless leg syndrome must be diagnosed via formal sleep testing. So if children are not responding to routine, consistent bedtimes, if we're not seeing any luck with behavioral modifications, it may be worth referring a family for a full sleep test. So like I mentioned, this is just a sample sleep diary. You can Google these. There's a bunch of different ways to do it. You can also make your own if that's easier. But you'll see, you have kind of a goal bedtime and rise time, and you're going to have parents answer these questions. So this is specifically written for adults. So we'll pretend, but what time did your child go to bed? What time did they start trying to get to sleep? What time did they actually fall asleep? How many times did they wake up? How long did that last? When did you get out of bed? And was there anything that interfered in your sleep? So again, this gives us a really deep dive and a lot of rich data to consider because, again, number of hours doesn't really tell us a lot. So behavioral modifications for improving sleep are usually kind of our first line of defense, especially when we're working with children and adolescents. So sleep hygiene, this applies to everyone, but is especially important as parents are actually teaching kids how to sleep and how to sleep well. So we want to be thinking about things like going to bed and getting up at the same time. So this may mean not sleeping in on the weekends in order to keep the sleep cycle the same. Avoiding caffeine consumption, and this also includes sugar consumption. So potentially cutting off high sugar drinks or highly sugared foods as we get closer to bedtime. The more sunlight exposure kids can get in the morning, the better. Um, and then parents also want to be sure that a child's bedroom is conducive to sleep. So they need a comfortable bed. It should be dark. It should be quiet. It should be cool. This also may mean like moving things that the child finds stimulating outside of the bedroom. So if kids are getting up to play on the computer, watch videos on their phone, play with toys that they have in their room, all of those things are competing with and interfering in sleep. Other sleep hygiene things include not going to bed feeling hungry, having a bedtime routine, which we'll touch on, as well as exercising kind of earlier in the day. This one is a little tricky and we'll touch on it, especially with adolescents. But sports practices often go very late into the day, and kids are often having to spend a lot of time doing homework later at night. And so we can really work with them to develop a relaxation and a consistent bedtime routine to help them wind down from those activities. And then finally, as much as possible, we want to avoid having pets in the bedroom just because they're fidgeting around, they're going to respond to noises in the house, and that has a chance and a likelihood of waking kiddo up. Like we have mentioned several times, having a consistent bedtime routine is perhaps the most effective way to improve sleep. So this is going to include not only a standard time to go to bed and wake up, but also having a routine of 20 to 45 minutes that takes place every single night. So it's recommended that parents choose about 3 to 5 activities to complete during that period of time. So that may include like taking a bath, reading a book, listening to relaxing music, drinking more milk, etc. We want activities to begin at the same time each night and move in one consistent direction. For example, if you're starting in the kitchen to drink a warm glass of milk, then move to the bathroom, do all of your bathroom things, and then move into the bedroom and do all of your bedroom things. So we want to avoid bouncing around the house as much as possible. Another approach is extinction. So this can look a couple of different ways. And the idea of this is that we really want to kind of phase out those problems and those behaviors that are getting in the way of bedtime. So the standard extinction approach is otherwise known as letting kids cry it out. This involves a parent leading the child through a healthy bedtime routine. So this may be calming music, providing a pacifier if they really need it, and then putting the child to bed drowsy but awake. And with standard extinction, the parents do not respond to cries until the morning unless there's a concern for health or safety. The idea is that eventually the child will figure out how to self-soothe themselves and go to sleep without the parent kind of coming in and out of the room to help them soothe and fall asleep. Graduated extinction, while slower, is sometimes preferred because it allows for parent-child interaction. Standard extinction is really hard on parents and can be really difficult on children. And so we can take a more gradual approach if that feels like a better fit. So it's very similar. With this approach, we go through our bedtime routine. The parent puts the child to bed drowsy and checks in on the child briefly at set intervals at times. So maybe we start out every 10 minutes. And then over time, we lengthen those intervals until the child is able to sleep through the night without parent interaction. So maybe one week they check in every 10 minutes, the next week they check in every 15 minutes, so on and so forth. Another idea that is helpful, because a lot of parents struggle with children asking for things or getting out of bed to go get water, ask to go to the bathroom, asking for a hug, etc. And the Bedtime Pass program helps alleviate some of these concerns. So under this program, kids have about 1 to 3 laminated passes that they can use for pre-approved activities, such as using the bathroom, getting water, giving parents a hug. However, once the passes are used up, the child is not allowed to leave their bedroom until morning. Then if there are any unused passes in the mornings, the child gets a reward for those unused passes. We know that kids respond well to concrete limits, and having those passes often reduces the anxiety because they know that they won't get in trouble for getting up with their passes. So they're allowed to get up and go to the bathroom, allowed to get up and get water, as long as it stays within those boundaries of what is determined by the parents. For children with nighttime fears, cognitive strategies can be really useful. So if children have specific fears of the dark, fears of monsters, anything like that, they can learn positive coping statements or brave talk to help manage those fears. We as providers can also help parents develop fun games to play before bedtime to reduce fears. So for example, one strategy I've heard of is like playing flashlight tag in the room to reduce fears around a dark bedroom or things lurking in the corner. So again, if we can make it fun, if we can make it a game, and if we can build that game into the bedtime routine, that sets consistency and clear expectations for the child. For some kids, having scheduled awakenings, if children are waking up with frequent and predictable, or they're waking up predictably at night, parents can try to wake the child up slightly before their normal awakening, and kind of help them go back to sleep. And as we do that over time, we gradually reduce those scheduled wake ups. This is a little challenging because it's not very common that nighttime awakenings are quite this predictable. But if they are, kiddos waking up at the same time every single night, we can schedule that in and try to predict it. And then finally, with younger kids, reward systems can be integrated with any other technique. So parents should identify specific attainable goals and determine appropriate rewards for their children. For example, sleeping through the night may be unrealistic at first, so we may start with staying in your room all night, and maybe we reward the child with 15 minutes of extra screen time the next day. It is important to note that sleep interventions have been shown to be effective with children with developmental delays and on the autism spectrum, but we may modify some things such as slowing down the pace or creating a visual schedule for bedtime routines to help them keep up. Now, as we're thinking about kind of older adolescent sleep interventions, there are some things that overlap and some additional things that may be helpful. So sleep hygiene is especially important in teenagers. They're overly busy with school and homework and extracurriculars and their peers. So really knowing how to wind down from the day is extremely important. Some specific things to consider, especially as we move into kind of teenager adolescence, is screen time and blue light exposure. So ideally, we would be cutting off screen time 1 to 2 hours before bedtime, but we know that this is challenging when teenagers are attempting to do their homework after school and after extracurriculars. So we can suggest things like taking breaks, using blue light glasses, and doing as much on paper as they possibly can, especially as we get closer to bed. So for example, maybe they can do the stuff that they need to do on the computer first, and then do their readings as we get closer to bed. We also have to be sure to talk specifically about cell phones. So many teenagers claim that talking to friends or watching videos on YouTube, that's the thing that helps them wind down and go to sleep. But ideally, we want to be trying to find other activities that reduce screen time and reduce that blue light exposure. We often have to involve parents in order to limit that phone time, and often really suggest that parents take up phones at night so that temptation is not even there. Like I mentioned, reducing physical activity immediately before bed may also be challenging, just depending on sports and extracurricular schedules. But relaxation strategies and building that into the bedtime routine can be really helpful for teenagers, because that is something that's going to be predictable, that can help settle the body and the mind. Finally, we want to talk to them about avoiding caffeine, and this includes energy drinks. So a lot of teenagers think that, energy drinks have no effect on them. Yes, they do. And we really want to be limiting how much they are drinking, especially as we get closer to bed. So like I mentioned, relaxation strategies can be extremely helpful. So this may include things like deep breathing, progressive muscle relaxation, visual imagery, listening to calming music, anything that helps a teenager feel sleepy. There's a lot of apps, if they are responsible and can just use the apps on their phone, that can actually guide them through like pre-recorded deep breathing or muscle relaxation, and that can be really helpful to get teenagers started. For teenagers who are experiencing those delayed sleep-wake cycles, we can use sleep phase advance theory. And this is just where teenagers are asked to keep a sleep diary for 2 weeks. And then they gradually begin moving up their sleep time by 15 minutes at a time until they have adjusted their sleep phases appropriately. So if they're normally falling asleep at midnight, we'll move that to 11:45 at first, and then continue moving it back until we're maybe at a 10 p.m. sleep time. Cognitive behavioral therapy for insomnia is useful for both teenagers and adults and is really the gold standard for insomnia treatment. It's especially helpful for individuals who are unable to settle their minds and bodies or have a hard time back to sleep once woken up. Treatment combines both sleep restriction and stimulus control. So teenagers reduce the amount of time they spend in bed. So that means no naps, getting out of bed and resetting when they're unable to fall back asleep. We limit the activity they do in bed. So we only want to sleep in bed. We don't want to be reading, playing video games, eating, only sleeping. And we also learn ways to relax and manage those ruminative thoughts. So our meme, this made me laugh as I was putting this together. We think we've all had those nights where, we're laying in bed, staring at the clock, counting down how many hours that we have left to get to sleep. And maybe we're having some of those thoughts like, I'll never get back to sleep, or tomorrow will be miserable. And so if we can use cognitive strategies to modify some of those thoughts, it can actually aid teenagers and adults into getting back to sleep quicker. And then finally, for teenagers with nightmares, imagery rehearsal can be useful for breaking the associations between fear and those nightmares. So in this treatment, teenagers imagine a new ending to their nightmares and rehearse that ending over and over. For example, a teenager who dreams that she's being chased may imagine that the person chasing her is her mother, and her mother's trying to tell her that she won the lottery. And if we can rehearse that new ending over and over, it can reduce the association and the fear with those nightmares. So again, there are a lot of behavioral techniques, and involving psychology or behavioral health consultation or a consultant can be really useful at nipping some of these sleep problems in the bud with or without medication. So, and Dr. Kerr, I will turn it over to you to talk about medications. Oh, you're muted.
Thank you. Yes, let's try that again. So moving on to some of our medication options. Before we kind of get into all the different options, I want to reiterate kind of what we've said multiple times, that we should always be using medications in combination with behavioral interventions, and definitely after we've done a good assessment and made sure that we've ruled out things like obstructive sleep apnea or parasomnia, things that won't necessarily respond to a medication, and which actually some of those can be exacerbated by some of the sleep medicines that we prescribe. So even though I probably have the most slides about medication of this presentation, it's really not the primary thing. The behavioral interventions and the sleep hygiene are really the most important piece of this. So again, we're always going to use these in combination with behavioral interventions. When we're talking with families, we want to make sure, we want to kind of address any of those unhealthy or unhelpful sleep habits that Dr. Simmons was talking about. It's helpful to review any previous medication trials that, what have they already tried? So, we've already tried melatonin and kind of anything else like that. It's really important at the beginning to establish your treatment goals. So kind of saying better sleep is very subjective. It means a lot of different things to different people. Does better sleep mean, Susie isn't waking grandma up anymore? Or does better sleep mean that Susie is staying in her bed for the whole time? So with our treatment goals, we want to make sure that we define expectations and kind of set realistic, clearly defined, and measurable outcomes. So this is where a sleep diary, as Dr. Simmons showed us, can be really helpful, both when we, before we start the treatment, so we can see where we started, and then also as we're going through using medicine so we can see kind of objective data as to whether or not we are seeing improvements in our sleep patterns, or maybe backsliding. And then you also want to, when you're picking what your treatment goals will be, you can consider kind of sleep or daytime behavior mood endpoints. So if our major issue is that our poor sleep is making us have more behavior episodes at school, that can also be a goal that we're measuring and trying to see improvement in. You want to make sure you have buy-in from, the patient, the child, and the caregivers. Obviously, this is more, patient buy-in is more important for our older patients, or, our adolescents. But it's important that the buy-in is not just the buy-in about the medicine, but also about the other pieces of the plan too. So we can try these medicines, but I also want to make sure that everybody understands the sleep hygiene things we're going to try, and this sleep diary, and making sure that it's a plan that you guys come up with together, and that also everybody agrees is feasible. If you're telling, the parents that Susie needs to be in a room with all the lights off and sister is older and leaves the lights on, well, that's not a plan that's going to be feasible. So you have to make sure you're talking with the family about what they can accommodate and what they can't. And it's also really important to have a plan for discontinuing. Ideally, we don't want to be on these medicines forever. Well, maybe this is a short term while we're getting through a phase or a more stressful time. So start talking about the exit strategy and what things were, again, those goals of treatment, so that we can be working towards that and making sure we have a clear kind of exit strategy at the beginning of treatment. Okay, there we go. Thank you. So when you're choosing a medication, you want to use the clinical assessment, the questions that you asked, the properties of the various drug options to guide your drug choice. So specifically, looking at things like a shorter acting medication versus a longer acting medicine. A short acting med would be more helpful with kiddos who are having trouble with sleep onset. They're just really struggling to fall asleep, but once they fall asleep, they are staying asleep for the most part. Whereas a longer acting medication is more helpful for those kiddos that, are just waking up multiple times in the middle of the night and really not able to maintain their sleep. And you also want to try to look at the kind of the duration of the medications and make sure that you're not having really long duration that's going to lead to kind of that morning hangover, still being drowsy the next morning. You want to review the use of any other psychotropic medications that the family may be on. So as Dr. Simmons alluded to, looking at stimulants, making sure we're not taking them, too late in the day and kind of interrupting our sleep pattern. And then also looking for any kind of drug-drug interactions. And also looking at medications that could be exacerbating or could contribute to exacerbation of coexisting sleep disorders. So for example, SSRIs tend to exacerbate restless leg syndrome, and then risperidone can be not a good choice in obstructive sleep apnea. You want to, especially this is more for our teenage patients, be asking about alcohol and drug use. Those are, things maybe we don't like to think about in pediatrics, but if we have kiddos that are using drugs right before bed, that may be something that's interfering, or using drugs at all. And then pregnancy is important. Pregnancy status is important to know about anytime we're prescribing medications. And then you just want to make sure you're asking about over-the-counter medications, including non-sleep medications, things that you might not think about, like CBD oil or anything like that is helpful to know before you're adding another medication. So when we're talking about using medications, there's a couple things to consider. The timing of administration may seem really obvious, like, well, of course I give it before bed, but there's some evidence of this forbidden zone of your circadian alertness that I think trips up a lot of parents. So about an hour before we fall asleep, our circadian drive actually increases a little bit. So if you're trying to give the medicine and get them to go to bed in that hour before their natural circadian drive starts to go down, you're almost like fighting against a brick wall. So that takes a little bit of kind of figuring out when do they seem to have this surge, right before bed, they're sleepy, but that's something to consider. You want to make sure that you're modifying the activities that are around and after administration. So this includes kind of that bedtime routine we talked about, but also, making sure we're not taking something that's a sedative hypnotic and then driving an automobile, or, making sure that we're not doing things that are going to really increase our arousal at the same time as we're taking a medicine, because again, we're just kind of counteractive there. You can do some dosing modifications. So some medicines you would want to take nightly, or in some instances it would be a nightly administration, but sometimes it may just be intermittent dosing. Maybe there are just certain situations that you need to kind of use them for just the sleep medicines for just a little bit of time. Some of the medications I'll talk about can actually be used for middle of the night dosing. So maybe it's a kiddo that's waking up a lot, you can give a middle of the night dose. And then you may have to escalate the dose as the therapy goes on. There may be a development of tolerance and a need for an increased dose. You want to go over the side effects of the medications before you start, and reviewing paradoxical effects as well. So effects that seem to be the opposite of what you might expect the medicine to be doing. You want to, again, monitor efficacy and the side effects throughout the treatment. This can be something you could add to the sleep diary, any side effects that they're having. And then avoid instructing families to avoid abruptly discontinuing these medicines, especially if you're getting into the higher doses. You're going to want to do a gradual taper so that you don't induce rebound effects. Rebound is more common with higher doses or with short or intermediate half-life drugs. And so going into the overall evidence about sleep medicines in pediatrics, the short story is there's not a ton of it. We don't have a lot of really well done studies for sleep medicines in children. Like with a lot of the medications we use in pediatric psychiatry, there are no approved or FDA approved medications for sleep in children. Now, there are some medications that have FDA approvals for other indications, and then there are some medications that have approvals in adults, but none have that FDA approval for the actual indication of sleep in children. So anything we're kind of talking about here is off-label. There are some medications that have evidence in the pediatric literature, so maybe some case studies and a couple randomized trials, but there's just not a lot. We use medications with FDA approval in adults and extrapolate that to adolescents and children often. One thing I learned when I was preparing this actually is that there are a lot of medications that we are commonly prescribing as pediatricians and child psychiatrists that really don't have as robust of an evidence base in the literature as I would have expected, kind of given how widely accepted and used they are. And then there may be more evidence, more of the studies are specifically looking at patients with neurodevelopmental disorders or, including autism, versus kind of typically developing children. So in the kiddos that are typically developing and their only issue seems to be insomnia, we don't have as many great studies for that population. So the first medicine that I feel like probably everyone is familiar with is melatonin, or sometimes people call it vitamin M. And just an overview or reminder, this is an endogenous hormone that's produced by our pineal gland, and it has hypnotic effects which inhibit the wakefulness drive, but it also is a little bit of a chronobiotic, meaning kind of helping that sleep-wake cycle, and so it kind of can help endogenously. It's an endogenous synchronizer and can help stabilize the circadian rhythm. It crosses the blood-brain barrier, and there is some evidence that it can have a role in mitigating hyperarousal and as an anxiolytic. The half-life is 45 to 60 minutes with a peak level at 1 to 2 hours. Dosing is a question I think that comes up a lot. If you're using it for more of that getting back on sleep cycle, which I'm not going to talk about as much, the physiologic doses are actually much smaller. But if you're trying to use it at bedtime, generally starting with 1 to 3 milligrams 30 minutes before bedtime is what's recommended. I know in the store, I don't see 1 milligram that often. I feel like you see the 3 and the 5 and sometimes 10. So that's something that you kind of have to encourage parents to look for. And then you want to increase it as needed by 1 milligram a week with a max of 30 milligrams if they're less than 40 kilograms, or 5 milligrams if they're greater than 40 kilograms. I often have people come in and say they're on 20 milligrams of melatonin, and really that's just way too much, and it's probably causing more side effects than anything at that point. And one thing that we have to talk with families about is that to really give melatonin a good, adequate trial, you should give it at least a month. And then about once a year, maybe consider discontinuing it and making sure that it, is it still needed? Is it still kind of doing its job? One thing that I thought was interesting about melatonin when I was studying this is actually, it's available over the counter here in America, but in Europe, it's a prescription medicine. It's not a medicine that you can get over the counter. So I think that that's something to think about. I think we think, oh, supplements, it's not a big deal. I know I get into this habit, but thinking about how it's perhaps to be prescribed in Europe is making me rethink how often I recommend it, I think. So some pros for melatonin. There is some empirical evidence for efficacy in typically developing children, as well as those with neurodevelopmental disorders. It doesn't have a lot of changes to sleep architecture. There's a low side effect profile, and it's kind of widely available at low cost. But again, the long-term side effects of using this at long-term is unclear. We don't have a ton of studies in psychiatric populations. And specifically, the reliability of the preparations is uncertain. There's a study that showed they looked at the melatonin content of these supplements because they're not regulated by the FDA. It can vary widely. And this study showed that of 71 supplements they looked at, 71% of supplements they looked at weren't within 10% of what they said on the label that they were. So, if they said it was 10 milligrams, it was either much more or much less. And 26% of supplements had serotonin in there, which is a little bit counterintuitive and may not be very helpful. So you want to make sure that, this may be used appropriately in patients with a circadian phase delay. And it's a reasonable choice, but you need to know and warn your parents that it may not, there's not a ton of regulation on it. And it's not going to be helpful in that sleep maintenance, the kiddos who are waking up multiple times. The next medicine is Clonidine, which I feel like is another medicine that has gotten a reputation as very widely acceptable and efficacious in this population. But I think that the information I got is that it's maybe not as widely studied as we thought. So it's the pros. It's got rapid absorption and an onset within 1 hour and peak effects at 2 to 4 hours, generally well tolerated. And this is a medication that has a short half-life that makes the potential for a middle of the night dosing. So if you do have a kiddo that's having night awakenings, this is a medication you could consider using. But there's not a ton of really robust empirical evidence. There's, some chart reviews and kind of parent report retrospective case series, but not a ton of kind of true randomized control trials in pediatrics about efficacy and tolerability. It does have effects on sleep architecture, and because of its short half-life, it can sometimes cause mid-sleep awakening. So it may be worsening the thing you might be trying to treat. Side effects, the biggest one is hypotension, but it also has some anticholinergic, maybe some irritability or dysphoria. You have to be careful about this one, especially if you get up at higher doses. Rebound hypertension can happen if you discontinue it abruptly, and it can exacerbate some of those parasomnias we talked about. You sometimes can develop tolerance, and it has a very narrow therapeutic index, so you don't have a lot of wiggle room. The next medicine, these are kind of the top three, I feel like, of ones that I use in my practice and hear people using, and I'm again questioning all my life decisions. Trazodone is a 5-HT and an alpha receptor antagonist, so that inhibits postsynaptic binding of serotonin and blocks histamine receptors. It is biphasic, so it can help with sleep maintenance because the half-life, there's kind of a peak at 2 different times, and the onset is usually within 30 to 120 minutes. It does have an effect on sleep architecture, and side effects: sedation, obviously, hypotension. There are some arrhythmias associated with it, and serotonin syndrome can happen. And the one we learned about in medical school, but I think is rarer, is a risk for priapism in males. Generally, you have to have doses up to 100 or 150 milligrams. There's not a lot of evidence for it being used as just for insomnia. There may be some evidence to use it for depressed adults, but they showed that in a trial with non-depressed adults, it actually showed modest effects, but without continued benefits for insomnia. And there were some impairments in memory and verbal learning. And then a study specifically looking at treatment-resistant depression in teenagers showed that the teenagers who were receiving Trazodone with an SSRI were 6 times less likely to respond to an alternative antidepressant trial that's compared comparing it to patients who were on no sleep medication. So it may be contributing to treatment resistance in treatment of depression. So something to consider about, especially if you have maybe a patient that you have on an SSRI and they're not seeming to do well and they're also on Trazodone. It may be something going on there. Antihistamines, so this would be kind of your Benadryl, and this is another one that I feel like is sometimes recommended. Pros, they have a rapid onset of action and a relatively short half-life, generally well tolerated, widely available, and these do have liquid formulations, but there's kind of mixed empirical evidence for their efficacy. You can have, some adverse reactions like anticholinergic symptoms. Some kids will have a paradoxical excitation. They'll get really hyped up on Benadryl. So that's kind of the opposite of what you want to be doing. And some kids can have a morning hangover. It's really common to have development of a tolerance of the patient. And so I don't recommend using this very consistently. This is something that's better for short-term, kind of situational or occasional use in younger children. But if you have a kiddo who has atopic disease, eczema or kind of allergies, this is maybe a good choice for them. And then getting into some of the ones where you're probably going to be talking to a specialist. This melatonin receptor agonist, the name is Ramelteon. This is kind of meant to be a little bit like melatonin, but different. It decreases the circadian mediated arousal at bedtime. It's not sedating and doesn't have a lot of changes in the sleep architecture. It also has a more consistent preparation than melatonin, like we talked about, and it doesn't have evidence of any residual daytime effects. You can use it for really as long as you want. There's no abuse potential. The cons, though, is that it really is only going to work with the treatment of sleep onset insomnia. It has some side effects like dizziness, fatigue. There's been some reports of increased prolactin or decreased testosterone. You don't want to use fluvoxamine with this. And the biggest con is that it's the cost. It is a newer medicine and a lot of insurances do not cover it. So this is not one that I am able to use very often. Gabapentin has some emerging evidence in a retrospective chart review of the 23 patients with a mean age of 7 and 7.2, 87% had diagnoses of neurodevelopmental disorders or psychiatric disorders, and then 70% had sleep onset and sleep maintenance insomnia. They noted improved sleep in 78% of children, but there were adverse effects noted in 6% of children, or 26%. I've seen this used a lot by pediatric neurologists, but one thing to consider is that this is a class 4 controlled substance in some states. It's not. I don't think it is in Texas, but it was in Kentucky where I trained. So you have to do kind of the controlled substance report, and then that can be a deterrent. And there is some abuse potential, usually more adults, but things to think about. And so just wrapping up with other medications, these are ones that I just really probably would not recommend except for very extreme situations. So benzodiazepines have limited utility in pediatric populations. They just have way more side effects, and they do kind of have effects on sleep architecture with a dependence and abuse potential. But maybe you can use them for their other properties like anxiolytic, and some of the benzos with longer durations of action may be useful. The non-benzodiazepine GABA receptor agonists, this would be like Zaleplon, Zolpidem, I cannot say that one. These don't have as much efficacy, documented efficacy for sleep in children, and they also have sleep-related behavior side effects. So they're really limited in utility except for older adolescents, and they do have a black box warning for those complex sleep-related behaviors because people were getting in car accidents or getting, doing things when they were kind of sedated that they weren't aware of. Antidepressants, SSRIs can actually sometimes be more activating. If you're going to try one, citalopram or escitalopram tends to have the least disrupting effects. But these can increase restless leg syndrome. Tricyclics like amitriptyline or trimipramine can affect sleep architecture, so they're not super great. And then if you abruptly withdraw them, they can lead to nightmares and parasomnias. Mirtazapine at a low dose can sometimes help with sleep. Antipsychotics, I think the risks outweigh the benefits in these. Some of them do have sedating, but the ones that are most sedating are clozapine, which I would not recommend for just sleep, olanzapine, which has a lot of weight gain, and Seroquel, quetiapine, which also has a lot of weight gain. And these can increase daytime somnolence. The last two I'm not going to go into because short on time, but these are some more experimental, newer things. Histamine receptor agonists, so like a low-dose doxepin, or this orexin receptor antagonist, which is suvorexant. That one I won't recommend because you have to have at least 7 hours in bed, or else you are going to not be functional. So if you can't get somebody to commit to sleeping for 7 hours, they're just going to be unhappy the next day. So I know that was very rapid, and then we don't have a lot of time left, but this is a very big topic that we tried to tackle today. So any questions?
We did have one that is currently in our chat. And from Lacey, what is the recommended age that melatonin can be started?
Yeah, so I think technically it says under 6 months of age, but I probably would not do under 2.
Under 2 years?
Mm-hmm.
Okay, wonderful. This is great information. We do have a couple of minutes left. I'm going to open up the chat, open up chat here. Go ahead, Dr. Simmons.
I was going to say, as a reminder, like all of the behavioral strategies can be started, I mean, as early as 6 months old, and really the sooner that parents can get that consistent bedtime routine in place and set those firm boundaries, the better.
Wonderful. And, you talked a lot, Dr. Kerr, about different medications, and, parents are often grasping at straws when they're trying to get their kids to sleep. And I suspect providers are hearing a lot